Hi, good morning. It's great to speak to you folks. I'm so sorry to be late. I hate to miss my own lectures. It's really poor form, so thank you very much for waiting for me. So I'm going to talk a little bit about glaucoma this morning. I know there's a huge range of experience and interest in glaucoma within the physician community. Within the technician community, I know some practices see more glaucoma and some less. So I've tried to cover a range from the basics to more cutting-edge stuff, and hopefully everybody will find a little bit of interest here and there, and if not, we will wake you when it's over, I promise. If there are questions, shout them out. I don't mind interruptions. So with that, let's talk about glaucoma treatments. So glaucomas, we have these definitions of glaucoma that are very diffuse, but more practically, I'm just a plumber. Glaucoma is a pressure-sensitive optic neuropathy, which means that it's a problem with the optic nerve, and that we treat it by lowering pressure. And right now, that's really all we have to do to treat glaucoma. We lower the pressure. You have an advantage in that regard, but we'll correct that. So glaucoma is a pressure-sensitive optic neuropathy, so we lower pressure and people do better. If you start off with a pressure that's very high, you have a lot of advantage, but even if you start with normal pressures and you have glaucoma, if your nerve is somehow too sensitive to pressure, lowering pressure really makes a difference, a huge difference in outcomes. In fact, several large studies have now shown that people who have pressure reduction reduce, for every 1 point they reduce their pressure, they reduce their relative risk of further damage by 10%. What does that mean? If you take your average person with glaucoma, they probably have a risk of having some worsening in 5 years of about 25%, let's just say. Average sort of mild to moderate glaucoma. So if you lower their eye pressure 1 point, on average, you can't tell this in any one person, but if you have 1,000 people in a study, you can. 1 point of pressure reduction will reduce their risk of further progression by 10% of 25%, by 2.5%. That means if you drop their pressure 5 points, their risk goes from 25% of progression down to about 12.5%. See? So it really makes a big difference, even these small changes in pressure. And these are just some of the studies that point that out. In general, as clinicians, we try to establish a goal pressure, and the goal pressure for most patients is a 20 to 30% pressure reduction. And if you actually have significant damage, we're trying to get the pressure under 18 for most patients. But this isn't written in stone. If the patient is 104 and the next step is some very invasive surgery, sometimes it's better to just hold pat even if you're not quite at the goal. Let's talk a little bit about medications. So again, the medications work by lowering pressure by different methods. We can either reduce the amount of fluid that the eye makes inside, so you get less pressure buildup, or increase the outflow. But in general, we are lowering pressure. There's one study I'm not going to really talk much about in which there's a suggestion that alpha-GAN protected the optic nerve better than timolol in low-tension glaucoma because it might be protecting the eye separate from pressure. That study is controversial, and I've mentioned it, but we really aren't going to go into it because there isn't consensus nationally on how much we should put stock in that. The problem, and this really burns up my patients, is there's no free lunch. I tell them, look, if it's going to help you, there's a chance, unfortunately, it's going to hurt you. And there's just no easy way around that. And patients have different reactions when I tell them this mixed message. It's interesting. Different people bring different things to their outlook on disease and life, and if you're working with patients, I'm sure you have all seen this. So here's an example. Here's brimonidine, a good drug for so many patients, but this is not a good drug for this patient. And so some people get allergies to eye drops, and they come in looking like they have conjunctivitis, but it's actually my treatment that's making them worse in this case. And we have to be aware of that so we don't throw another drug on top of this, treating the reaction to the first drug, steroids on da-da-da-da-da. I like to tell patients to do punctal occlusion. It's a nice thing to tell them. Punctal occlusion is when you put the finger in the corner and you compress the puncta and the canals so you lose less medication to the tear sac. Why? Because medication going down the tear sac is where it gets absorbed in the bloodstream, and people get more systemic side effects because of that. Also, as it runs out away from the eye, it does not get absorbed in the eye. So by doing this, holding this there for at least a minute, but preferably 2 or 3, the patients can dramatically increase the effectiveness of the eye drops they're on to lower pressure and reduce the incidence of side effects. I do not tell my patients to yank on their eyelids and stretch them out all sorts of ways. I tell them, some people feel it has to hit the pupil. Some people stick the bottle tip against the skin here to make sure it gets contaminated. I try to tell the patients to gently just sort of pull the lid a little bit, and if they get it anywhere between the eyelids and close their eye for a minute or two, I call that better than most people are actually achieving. I'll settle for that. I often tell patients to hold the bottle like a dart in one hand, gently pull this down with the other hand, and as they then do that, and they hold the two hands against each other, it just lines it up. It takes the whole, this business, when you see them doing this, takes it out of the equation. It steadies everything, and it requires less vision to achieve that, especially when they're dosing their bad eye. Or if they're phobic, and when they see the tip in front of their eye, they blink each time. So, again, a lot of physicians feeling a little time pressured. You guys may have the opportunity to do some excellent education for patients on this. For patients who have a stiff neck and can't lean back, those patients you can tell them to lie on their bed or sofa and to just lie down and do the exact same technique. And for some patients, that's helpful. So unfortunately, as good as our eye drops are now, the prostaglandin analogs and stuff like that, about half of all patients nationally who are treated for glaucoma are on 2 or more medications. So how do you choose the second medication? Well, if I arbitrarily just choose a bunch of eye drops here that we often use, and I could throw another 5 medicines we often use. I could say, well, these are some second choices I could go to from timolol, and then these are some second choices I could go to from brimonidine, and you can see how, I could spend from here to eternity seeing this patient once a month trying to find the perfect combination. And there is no perfect combination for most patients, but there are often many very good combinations. And so this is all a bit of an art and a science, depending on what the clinician brings to this, depending on the patient's own preferences in terms of frequency of dosing, depending on the patient's exact type of glaucoma. We may have certain biases. And maybe you've heard that sometimes it even depends on insurance coverage, right? So working through the copay issues in these discussions can take up roughly your entire life. So art and science probably shouldn't just go for a random shoot. In most cases, we're substituting before we're switching. So if you don't respond to one medication, often we'll try a medication that's in a different class. An exception to that might be Xalatan. There are some concerns that for some patients, generic Xalatan is not as effective, and so physicians may try a different prostaglandin analog. In general, we don't want to really burden our patients too much with bottles of medications because we know for every extra eye drop we ask them to take a day, for every extra bottle, their compliance, their adherence, their use of the medications plummets. Okay, on average, patients take 70% of the eye drops we tell them to. I suspect if you did the same study in physicians, it would be 50%. So I'm not trying to castigate our patients. They're doing the best they can, but we're all human. Many of us may have ourselves had a cold or antibiotics and not finished the antibiotic prescription. The same things happens every day, and people forget their eye drops. In fact, one study by Gail Schwartz, who's down in Baltimore, found that of people who were started on a new medication, at 1 year, only 60% and maybe less were still refilling that medication at a year. So lots of those patients who we send out of the office with an eye drop, that's the last that they are ever seen. Who knows? Land of the lost. So we all think our patients are using their meds because they are kind and they say to us, I'm using my meds, they don't want to be rude. And also because many patients who aren't using the meds also aren't coming back anymore. And the failure to follow up is a huge issue in glaucoma still. One thing that's easy to forget about is these are systemic drugs. I put it on the eye, but it gets into the rest of the body. And so my patients who are thinking about becoming pregnant or in an age range where they may think about becoming pregnant, I like to talk with them about eye drops because most of the drops we don't have human studies showing that they're safe, and most of the drops in animal studies at high doses have some suboptimal effects on the unborn fetus. The exception is brimonidine. Brimonidine, or Alphagan, is actually well tolerated in animal models, but we don't have human models in pregnancy. So brimonidine is a decent drug for pregnancy. It's a very poor drug for newborn children. So as they get close to delivery, this is not the drug to be on. But it's a decent drug. Now, many patients who are pregnant, their eye pressure actually will drop during pregnancy. So thankfully, this is often not that big an issue. And timolol and other eye drops have been isolated from breast milk, and that's another thing we have to keep in mind. In terms of allergies, almost all the drugs are BAK except for Travatan Z and Alphagan P and the non-preserved medications that I'll be talking about in a little bit. One thing you can do if you really want to make a difference in some of these people's lives, your patients who are having trouble affording their medications will often qualify for pharmaceutical company-sponsored assistance programs. And so if your office is inclined, you can keep these forms around and fill them out for patients. It's a bit of a pain in the neck, and I think, frankly, that's done to discourage us from doing that for every patient. At the same time, for many of my patients, this is why they're able to be maintained on eye drops. And my technicians are very kind, and my study technicians too, and fill out roughly 1 million of these forms a week, and I am blessed not to have to look at them. But it really helps people. So, yes?
For like offices like myself, I don't have paperwork to fill out, but Alcon is alconcares.com, and Allergan is rxhope.com, and patients can go on themselves, so we give our patients the website to go on, and it seems to be really good.
And that's a great point. Self-empowering the patient is always good. It's good for the patient. It's good for your office. Great point. Thank you. So let's talk about the newer medications in glaucoma. So this is a list of things that have come out really in the last year or two, last year for these two, and one thing that's coming soon. So Timoptic, Ocudose, preservative-free is timolol in little individual dose packs. And we also have Cosopt, which of course is a combination of dorzolamide and timolol in individual dose packs. How many people are using this in their practices? Okay, so you guys are familiar with it. It's a bit of a form factor. The patients have to realize and understand how to use these medications in a slightly different dosing pack. Most patients seem to be accommodating it pretty well unless they have particularly bad arthritis. And the nice thing is this takes away, I hope, some of the excuse, oh, I didn't realize I was at the end of the bottle. If you don't realize you're running out, we got a problem. This is not a patient who should be on eye drops. If they can't figure out how many doses they have left, we should move on to something else. The insurance coverage for these medications is variable, and that's, again, one of the hurdles that we work through. The efficacy of these is the same as the preserved version. And you may be aware that for many patients they have a BAK allergy, and many patients have real sensitivities to many of the eye drops. And for patients who have dry eye syndrome, these chemicals, the BAK and other preservatives, can really exacerbate the dry eye syndrome. So this can be a gentler and easier tolerated choice of medications. Timoptic Ocudose is by Aton Pharmaceuticals, and Cosopt PF, of course, is by Merck. So two different companies with these products. Some patients won't be able to tolerate Cosopt because it's a sulfa drug, although most patients who have a sulfa allergy do not have an allergic reaction to Cosopt. Another issue with this is the pH is low, so it stings. It's harmless for most patients, but about half the patients will complain of several minutes of burning and stinging. You might as well warn them about that up front, tell them it's normal. So some considerations for Cosopt. Now, Xioptan is a truly new medication just released in the last year that also comes in preservative-free. Xioptan is a prostaglandin analog like the medications. Oh, one more word on Cosopt. A lot of patients will see in the title dorzolamide, especially if they're on generic Cosopt, and so they'll tell you they're on dorzolamide when they're actually on the combination product. And the reason that's important is because if it's recorded wrong in the chart, the physician may then add a beta blocker. And a beta blocker on top of a beta blocker, I mean, at some point if you block the betas enough, the heart will throw up the white flag and slow down too much, or they may get an asthmatic response. So really being clear with patients about that or coaching them so they can be clear to you is helpful. Anyway, back to Xioptan, tafloprost. So tafloprost is a prostaglandin analog, much like latanoprost, bimatoprost, and travoprost, or Xalatan, Lumigan, and Travatan. It is once daily dosing. It's preservative-free. It has a lower side effect profile than the other prostaglandins. Many patients with prostaglandins will have injection, hyperemia, the conjunctiva. They will have itching for some of them. much lower rates of itching and redness with tafloprost or Zioptan compared to the others. On the other hand, its efficacy is perhaps not quite as great as Lumigan, Travatan, and perhaps Zalatan. It has an efficacy that's a little bit less, somewhere close to Timolol. So it's not a weak drug, but it's maybe not quite as strong. However, for many patients who are intolerant to eye drops, this can be an excellent choice. And again, you have to ask yourself the question, if it was your eye, would you want to start with a medication with preservatives? That's just something to think about. Rescula. Now, Rescula is both new and old. For those of you who are significantly younger than me, you will think of Rescula as a new drug, and it is with a new company and newly marketed back in America with Sucampo. On the other hand, Rescula came out in the mid-90s in Japan. It then became marketed here in America in the late 90s, and then it was bought by another company, Novartis, which was a very large company that basically couldn't figure out why they cared about this small drug, and in the early 2000s they basically just gave up making it. Rescula is structurally similar to the other prostaglandin analogs, but it's really not the same in how it works in the eye, so it's not really acting like a prostaglandin. It is a twice-daily dosed medication. This will not be effective with once-daily dosing, even though it looks like a prostaglandin. Additionally, it has a remarkably benign side effect profile. I mean, Rescula, if you can't tolerate Rescula, you really are sensitive in terms of your eyes. The vast majority of people have very little in the way of anything other than a little bit of stinging upon installation. You know, redness, itching, all these things, blurry vision, really not very common with Rescula. However, Rescula is not as strong at all as the other first-line prostaglandins. It is not as strong as Timolol. It is a second-line agent. You might want to use it in addition to one of these other agents, in addition to Timolol, twice-daily dosing like our other second-line agents like Trusopt, Azopt, and Alphagan, or Brimonidine, Dorzolamide, and Brinzolamide. But at the same time, it's not quite as strong an agent. But it's well tolerated, so there is a role for this. You're going to see it being sampled in your offices very soon if you haven't already. And there'll be people coming by to help you understand why you should prescribe it in every patient. We call those pharmaceutical representatives. Excellent. Now, the other big news, which isn't even here yet, but is going to be here depending on the FDA's actions in the coming weeks, we'll probably see it in the next 1 to 2 months, is a combination product from Alcon combining Brinzolamide or Azopt with Brimonidine. This will be a twice-daily medication that will have fairly good strength and fairly low side effects. Obviously, anyone who's been allergic to Brimonidine or Azopt or Trusopt, probably this isn't going to be the medication for them. But for a lot of patients, this may be a powerful second-line agent. In general, we don't start with combination agents as first line, and because it's twice-daily dosing, we usually start with a once-daily dosing for most patients. I guess the main reason, just to remind everyone, I'm sure you all know this, but the main reason that some patients will not want to take prostaglandins off the bat, other than it makes their eyes red, is that some patients will change their eye color, will make it more brown. Having had brown eyes my whole life, I don't know what's wrong with them, but for people with hazel, mixed color, or green eyes, that's actually not at all uncommon for it to start turning the eye brown after a period of months or years. So for some people, that's an issue. On the other hand, it does make eyelashes longer and darker, it's true, the prostaglandins. So what happens when medications fail? So what happens? Why do medications fail? People are intolerant, their pressure is not adequately reduced, they can't keep using the drops because they keep forgetting, they're getting worse despite the fact that they're on medications. Those are the main reasons we move on, the most common of which is the pressure just hasn't come down enough. So then we move on to laser or surgery or some other things that we should go through. So laser trabeculoplasty. How many people do laser trabeculoplasty in their office? How many people the surgeon goes off to an outside center? Yeah, it's fine. It's become less and less common, the outside center. So argon laser trabeculoplasty was the gold standard. Then about in the year 2000 or so, we got selective laser trabeculoplasty. Selective laser trabeculoplasty uses a much larger spot size and much, much less energy, but the results are extraordinarily similar. Very, very similar. There's some suggestion that the SLT may be a little more repeatable, but very similar results. They're both good treatments. Obviously, but these are treatments only for open-angle glaucoma because we're taking the laser and we are shooting it in and treating the trabecular meshwork in the angle. And it doesn't make holes, but it stimulates that tissue. It stimulates the cells to release certain cell signaling proteins, things like interleukin-1, TGF-beta, and things like that. And those tell all the cells in the trabecular meshwork to pick up the pace. Some people have said that it's almost a rejuvenation of the trabecular meshwork, increasing outflow. So trabeculoplasty is a very safe technique. When performed appropriately, serious complications are terribly rare. Occasionally a pressure spike, but that's usually not a big deal. You don't do it in angle closure glaucoma because, of course, the trabecular meshwork is partially or completely covered by the iris, and so that's not a good time to go trying to shoot the trabecular meshwork with a laser. Unfortunately, it doesn't work in everyone. I tell people that it fails in about 1 out of 4, 1 out of 5 people. I tell people I do it and nothing happens 1 out of 5 people. That way, when they come back in a month or two and nothing's happened, they're a little less steamed about that. But what can you do? That's the nature of the procedure. Very safe, though. On the other hand, it's also not permanent. I've heard a physician joke that the perfect treatment for glaucoma would last 90 days. That's because it used to be you could only bill for a surgical treatment every 90 days. I tell you, a lot of cynics out there. But this is not the perfect treatment, both because it lasts on average, I tell people about 3 to 5 years. Some people would argue 2 to 3 years. You'll meet patients where it's been 7 years and it's working great, and you'll meet people after 6 to 12 months. It's really failed. Occasionally, if you do it a second time, it may work for a while, although the success rate of round 2 is not as good as round 1. So, if a patient's gone 4 years with a good effect, worth trying again. On the other hand, if it is 6 months, can't get too excited about doing it every 6 months. Myself. This just shows you it's a smaller spot size for ALT than for SLT. This makes this procedure a little easier. It's just a hair more comfortable for patients. So once that fails, or if they're not a candidate, or if they have the pressure, if you have a pressure of 30 and you need a pressure of 15, very unlikely SLT is going to get you there. So for all those reasons, we move on to more exciting events. A trabeculectomy where we create the bleb, the blister that collects the fluid from the eye under the eyelid. The tube shunt, they don't all have to be quite that long and nasty, which drains the fluid to a reservoir where it's absorbed into the blood vessels around the reservoir above and behind the eye. These are newer glaucoma surgeries. So how many people in the audience work for doctors who do trabeculectomy? I know some of these people. How about tube shunt? That's pretty good showing. How many people have doctors who do any of these? Yeah, ECP. So, and then these are other things. So I'm going to march through these newer surgeries just so you have a sense when you hear about some of these, what we're talking about. Before I do, so in general, a key issue with glaucoma surgery is that it does not improve vision. You know that. I know that. They don't know that. And sometimes they know it, but then they forget it. So not that infrequently, once or twice a year, I get someone who's very happy patient, very content, and I say, okay, you're all done, you can go back to your doctor who sent you here. And they say, yeah, but when is my vision going to get better? And that's just so disheartening. And I try to get it across to people, this is really just to try to preserve vision. I can't make the vision better. And all of us need to reinforce that because we want our patients to not have disappointments that can be avoided from unrealistic expectations. Also, this is not cataract surgery in the sense that cataract surgery, sometimes people say, I barely feel a thing the next day. My vision's so good. This is not what your post-op glaucoma patient says. Post-op, you got this black eye, Much more exciting event. So trabeculectomy, we're making a little drainage channel, creating that blister called the bleb under the eyelid. The bleb there, maybe an iridectomy, it lets the fluid get out. And the key is how tight is that flap. If it's too tight, the pressure's too high. If it's too loose, the pressure's too low, and that's a misery. And this shows you the exciting surgical technique. I always like animations in cartoons because there's no blood around. You can't hear the patient moaning. There are a lot of things that influence success in trabeculectomy, and that's one of its many failings, is that it's not equally effective for all patients. In general, older patients who have thin conjunctiva and open-angle glaucoma do better. If you have inflammation, if you're of African-American descent, if you're a child, this procedure is much harder to get working right, much more prone to complications. And this shows you that the bleb can be diffuse and low and not necessarily unsightly. This is a surgical iridectomy. We don't always do those. This bleb, though, is big. It's encapsulated. It's expanded. It may be symptomatic. The pressure may be too high because it's too thick-walled. suboptimal. That's an ugly avascular bleb. There's nothing nice about that. Maybe it's more prone to leaks and infection, more prone to dysesthesia or discomfort. And part of the problem is it's not the surgeon often who determines which of these you get. It's how the individual patient's tissues choose to heal. And that variability in healing is a major stumbling block for trabeculectomy. This is an avascular bleb with a little bit of an angry injected eye around it. Nonetheless, the success rate in first-round surgery is pretty good, approaching 90%, and many patients will have 5 or 10 years or even more. I've met a patient who's pushing 30 years out from a trabeculectomy, still working fine. But there's a late risk of infection. So if you have a patient with a trabeculectomy who comes in with what looks like a pink eye, you have to assume that that's a serious bacterial infection until proven otherwise, because it can lead to endophthalmitis and loss of the eye in a day or less. These are some of the complications of trabeculectomy. Sadly, I've caused all of these many more than one time. It really happens even when you're trying hard. You can tell who's going to get what complications some of the time. If you have a 95-year-old with high blood pressure and a pressure of 40, that's a suprachoroidal hemorrhage. And a non-compliance, they get failed follow-up, they get failure because they don't use the steroids, inflammation, etc. That's a bleb that's full of pus and infected, and that's dangerous. Here's an encapsulated, thick-walled bleb. It's funny, this bleb here, which is absorbing fluid great, it's sitting on the eyelid, and that looks like nothing, and yet it can drive people crazy. They get this irritation like there's an eyelash in their eye, and it burns, and they hate it, and we have to go back sometimes and fix it surgically to make it smaller. Bleb that failed and scarred, more infections. So it's effective. It's a bit of an art. It's a little bit like rolling the dice some days. Tube shunts. Tube shunts are a little bit more dependable in that there's less variability. You take a tube and put it in the eye. It goes to a large plate. This plate here is where the fluid's absorbed. And this is a different model that has a valve, so hopefully it doesn't let too much fluid out of the eye. Just different older approaches, different types. And there's a tube in the eye, pupil, iris, there's your little tube. And they're very well tolerated. We do them often when a trabeculectomy has failed or for people who have a high risk of trabeculectomy failing because the tubes are a little more resistant to scarring. The tube shunts can create all of the complications that I've achieved with trabeculectomy, but they raise you one more with diplopia. So about 1 or 2% of people, because the tube's back near the muscles, after they have a tube shunt, will develop a diplopia where when they look in the direction of the tube, the eye doesn't move all the way up in that direction. And for those of you who have seen patients with double vision, it can really make people unhappy. 20/20 times 2 is not as good as 20/20 times 1. Live and learn. So luckily that's rare. It often goes away on its own. It's not well treated with prisms. Very rarely it means we have to take the tube back out. So tubes, again, often when trabs have failed or when you think your trab will fail if you try it. So what happens if all of that fails? Well, you can go cyclophotocoagulation, where you take a very strong laser and you shrink or destroy the part of the eye, the ciliary body that makes fluid, and that keeps the pressure down very effectively. It's very quick, takes 10 minutes in the OR, sometimes causes a bad headache for a day or two. And then there's a fairly pronounced 10 to 20% risk of delayed vision loss in the coming 18 to 24 months. And because of that delayed vision loss, we don't usually do this early on unless we have no other options, unless it's a poor seeing eye. There's also about a 1 in 1,000 risk, is how it's quoted. It's probably less than that you do the laser in the bad eye and they get uveitis and inflammation, something called sympathetic ophthalmia in the good eye. I've never seen a case. I hope that continues. It's a big deal, and if you talk to patients about that very small risk, many of them won't be too excited if they have a bad eye and a good eye, taking any risk in the good eye. But then there's ECP, a more modern version of this procedure. These procedures, I said, reduce the amount of fluid made by the eye and can have complications. Well, ECP, this is the pupil, and this is the artist's rendition of me gently taking this hot poker and using the laser to shrink the ciliary processes behind the iris. This can be combined with cataract surgery. In fact, you generally only want to do this in someone who has a lens implant, because if you bump into the normal lens with your hot poker, you can cause cataracts in the short and long term. So much easier to do. There's more space in a pseudophakic patient. This is endoscopic. That means that on the TV screen next to me, I'm actually seeing the view from the tip, and it's pretty cool to march around the eye and look directly inside and see what you're shrinking. And you can titrate the energy to shrink the processes just enough. The other versions of the laser and the freezing are from the outside of the eye, and it's sort of high power, not quite sure exactly where you're hitting or how much you're hitting it. This is a much more delicate event. Thankfully, it's not yet been associated with that sympathetic ophthalmia, hopefully never will be, and some of the devastating sight loss complications don't seem to be at all common. So it's better tolerated. Sometimes you get some inflammation. Works for mild glaucoma. Very severe glaucoma isn't usually where we go. Express shunt. So I talked about trabeculectomy being a drainage channel under a flap. The express shunt, rather than punching a hole in the white of the eye with a little punch, the express shunt is a little rivet that goes through, a little steel rivet that goes through and into the hole. Ta-da. And that really is what happens during the surgery. You just open up your flap, and instead of making a hole, you put the express shunt underneath. Some people believe that by standardizing the size of the hole and the way the fluid gets out of the eye, you're going to have more predictable outcomes and less failure. They may be right. There are very, very limited studies to show for certain what the role is for this in the eye. Some surgeons use it, some don't. But the newer techniques are really about avoiding the bleb, because I showed you those pictures of infected blebs. They cause such trouble for some patients that the newer surgeries were trying to open up the area where there's resistance, the trabecular meshwork, and get fluid into the natural drainage channel without creating new channels. So cardiologists like to do stents. Why don't we all do some stents? Well, the problem is the blood vessels are much bigger than the trabecular meshwork in Schlemm's canal. So now Glaukos is making something called the eye stent, where a 1 millimeter titanium snorkel is stuck into the trabecular meshwork. This is just like doing an IV, except a little smaller. And so the surgeon goes across the eye in conjunction with cataract surgery, and it sticks this into Schlemm's canal, getting the fluid past one of the sites of resistance. Generally is indicated for mild to moderate glaucoma, and right now in America it's only being used in conjunction with cataract surgery. In other parts of the world, being used other ways, but our FDA and the certification process works in mysterious ways. This just shows you the dimensions, about 1 millimeter, the lumen of the tube, less than 1/3 of a millimeter. This is a small titanium object. Because it's titanium and it's not magnetic, meaning there's no concern about things like MRIs. This shows you, just to give you some scale on how big this guy is. Doesn't project very well, but that's what they look like when they're stuck in there. You can sort of see them through the very fine trabecular meshwork. This happens to be one that I stuck in as part of the U.S. trial. The patient did well with a reduction of pressure from 34 to 17. In the studies, the primary goal was to get the pressure under 21 at 12 months without medications. And you can see that it worked in about 3/4 of patients. About half the patients, cataract alone in mild glaucoma, will often lower pressure. So half the patients who just had the cataract had a pressure reduction. About 3/4 of the patients who had the eye stent. In terms of getting the pressure down at least 20% without medications, 2/3 versus about half of the patients. So the eye stent helps some. There's evidence that 2 eye stents are better than 1. I'm actually not kidding about that. But right now in America, most insurance companies aren't paying for the second eye stent. They cost about $1,000 a shot. And so that raises issues. I think I'll just have my technicians have that discussion, Sue. You're on it. So another option is the trabectome. So again, we're trying to get past the trabecular meshwork where a lot of the resistance is. We could take this hockey ski and this electrode. So imagine an irrigation aspiration device. Fluid is coming in here and being sucked back out through the sleeve. And you have a hot electrocautery thing here. They say it's not hot. It's a radio frequency electroablation. Looks hot to me. Anyway, so you stick this ski into the trabecular meshwork into Schlemm's canal, and as you skate along and turn on the electricity, it cuts open the trabecular meshwork. And that clearly will reduce resistance and open things up. It's a much more fun procedure to do than a trabeculectomy, so surgeons like it. But does it work? Well, it depends who you ask. Doug Rhee was on staff here for a half dozen years and then went up to Mass Eye and Ear. He did a study comparing his trabeculectomy patients to his trabectome patients, and trabectome is the name of this device. You can see it was a 22% success rate at 2 years. Set expectations very low. You have a 1 in 5 chance that this might work. Tough discussion. Again, Sue, you'll be on that. So because of that, most of us aren't doing a lot of trabectome. There are isolated patients in whom this may be the best thing, but its success rate in the long term isn't great. There's some suggestion that if you combine this with cataract surgery, the patients may do better. Of course, cataract surgery alone lowers the pressure, so it becomes unclear how much of it is the trabectome. Now again to more fun things. So here we have opened a flap in the white of the eye, and from the outside in we've found Schlemm's canal, and the trabecular meshwork is right through here. Forget this tubing here, that's from something else I'll show you in a minute, but we could take this whole fancy cannula and stick a tube into Schlemm's canal. Okay? First you have to find Schlemm's canal from the outside. Not a lot of fun for a lot of surgeons if you haven't done a lot of kids. And then you stick this probe in there. Let's see if it works. Nope. So here we are. This is a surgery where you see the flap and they're sticking a probe in there and it's got a flashing red light so you can see how far along the circumference of Schlemm canal you've made it. And why do you do this? Well, it's cool. You know, it's cool. Now, the reason you're going to do this is once you have stuck this probe all the way through and all the way around, you're going to tie a suture to the probe, pull the probe back out, and now you'll have a suture through Schlemm's canal. That's even more cool. And so you tie it off like a belt, and when you cinch it tight the right amount, it pulls on the trabecular meshwork and stretches the trabecular meshwork, increasing outflow. And then you suture everything up, and they don't get, hopefully, a bleb, and they do have increased flow through the natural system with reduced complications associated, like the ones associated with trabeculectomy. It's technically challenging surgery. The key is to tie it tight, the right amount tight. If it's too loose, it doesn't do much. If it's too tight, it tears through in the anterior chamber, and you've just spent a lot of time doing something that the trabectome could have done in about 5 minutes. Does it work better than trabeculectomy? Ramesh Ayala is this very aggressive but also technically very good surgeon down in New Orleans. He did a series of patients, and basically at the end of a year, very similar results to trabeculectomy. Trabeculectomy may be a little bit more effective. Canaloplasty may be a little less complications, but technically more challenging. Unclear how widely across the U.S. this is going to be adopted. There are people who are passionate about it. Time will tell. So now we get into the wackadoodle mode. Just kidding. Let's just say the things that have not yet hit prime time. So let's take a piece of collagen. You know, the main reason for a trab to fail is because of scarring. So somebody said if we stick collagen in here, maybe it will keep the trab open. Either a trab or this is a non-penetrating where you leave a little bit of TM there rather than going all the way into the eye. Really no good data to say it has better outcomes, but for a few years they were able to sell a bunch of these before it became clear that it really didn't make much difference. So we should stick to the collagen in the face, not in the eye. Pneumatic trabeculoplasty. So a bunch of people measured eye pressures after LASIK and PRK, and they found that the eye pressure was consistently lower in most patients after LASIK and PRK. And they thought to themselves, it's because we stick that suction ring on the eye. That's got to be why it does it. So they started to market suction rings to stick on the eye for a few minutes to lower the eye pressure. I was down at Duke at the time when they started to do these trials, and what they found was essentially that it didn't do a thing. Around the same time or slightly thereafter, research showed that when you thin the cornea out, because the cornea is thinner, the pressure measures lower. And we all recognize this now 15 years later. And so what they thought was the suction, that was really just a question of the PRK and the LASIK thing in the cornea. It's all artifact. So you won't see a lot of this, but it was an example of commercialization getting way ahead of the science. In the hot poker department, this is an excimer laser trabeculostomy. You stick the hot poker in the eye and you blow a hole through TM to Schlemm's canal. Instead of sticking your eye stent through, instead of making it open with the trabectome, you use this laser. Not approved for use in the U.S. yet. Historically, every laser that's been tried, and there have been about half a dozen lasers from the 1980s to now that people have tried this with, they've all worked initially and then scarred up later. But this is the newest kid on the block of the new improved, more gentle laser. We shall see. And here's truly bold. So imagine that you had a rivet, a steel rivet, and that had holes in it, and so it could let the fluid out. But what if you made the holes so small that no bacteria could ever possibly find its way in through those holes? Right? They're too small. And then all you had to do is you'd stick the rivet into the cornea. What could be simpler? You treat dry eye syndrome and glaucoma at the same time. It's a 2-for-1.
Sounds like a great idea. You'd need a bold surgeon. Well, one of the boldest and best surgeons I know is Dr. Marlene Mostert, and she was the lead investigator at this at Wills Eye Institute. And she is a great surgeon, and she put these in, and she did them well. But let's just say it really did lower pressure, and that question about whether it keeps the bacteria out is uncertain, or at least for some people it didn't. So this was in phase, it was in U.S. trials, and after just a few patients, basically, it was taken off the market because it really had a lot of complications. So it was a bold approach, it was a creative approach, but the technology wasn't quite there. And the last one I'll talk about is the bidirectional shunt. This is 2 pieces of tubing. You stick them in Schlemm's canal, and you stick the end, this end here, into the eye. It's away from the outside of the eye to do the same bypass, essentially, that we're talking about with the eye stent. Now, it's interesting, now, though the eye stent works pretty well, in U.S. trials, this did not work well at all. And Rick Wilson was the main surgeon on this, another very gifted surgeon here at Wills. And even in his hands, it wasn't very effective. Although in Germany, they had a little better success. I don't know what to say about that, but in America, it was all closed off. Oh, sorry, this last one. This one may yet come to the U.S. There are some investigations in the U.S. So this is a wafer of gold. You got to have bling, 24-karat gold. The wafer is closed, and there are these channels, and some of these channels are open, and some of them are not open, okay? And this shows you how big the wafer is. And you take that, and you stick it right into the suprachoroidal space. So it's bypassing from the anterior chamber to the area between the retina and the sclera, okay? It's not going out the normal way. But that is an area where fluid can get out. And then the idea is that later, if the pressure is too high, you can use a special proprietary laser called the Sol-X laser, and you can open some of the channels that are closed. So you take it, it's not quite working well enough, so you can sort of titrate and increase the outflow. It's clever. It's interesting. I think it will be easier to sell gold in the eye than some of these other things. But the trials so far suggest that its pressure reduction isn't quite as good as, say, the average tube shunt, at least in the limited trials we have. So I'm not sure if it's going to pan out or not, but there are some trials starting in the U.S. So it's an exciting time to be a glaucoma surgeon. We have more toys and techniques than ever before, but most of these aren't going to wind up being the main event anytime in the next 5 years. But it makes it a much more complicated discussion sometimes with our patients now, which is good that we have more things to offer them, and for some patients, better things. If you are interested, I'm sorry I didn't have a handout for this. I missed the deadline. But if you're interested in these slides, I can at least send you the text, if not the pictures, if you want to email me about this or any other glaucoma questions or stock tips. A pleasure speaking with you today. I hope you enjoy the rest of the conference.